Thank you.
So, first of all, I thank the organizers for giving this opportunity. Optic pig maculopathy, again, is another type of schisis I'm going to talk about. I'm very interested in the subject, but not financially. And I acknowledge that all the pictures and studies I'm going to show was the result of my work at Arvind Hospital. Now, what's an optic disc pit? It's a congenital excavation on the optic nerve head, which is typically sporadic and unilateral. It can occur anywhere on the optic nerve. Anywhere on the optic nerve. This is in the macula. Quarter to 3/4 of the cases. Now, what is the natural history of this schisis? It generally persists in over 3/4 of the cases, and in 80 to 100% of these cases, that is most of the cases, it causes significant visual loss, and probably therefore treatment is required. Now, how did our understanding improved on this interesting topic? It was called, I remember when I was doing fellowship in Arvind, it was called a PIT, optic pit with CSR. One of the first people to call it a retinoschisis was Linkoff, and his brilliance lies in the fact that he said so before OCT was available, which of course confirmed his findings. Schisis is now considered central to the maculopathy in optic pit, and it starts at the edge of the macular edge of the pit. It involves multiple layers, and detachment develops only later on. And now most authors believe that the source of this, it's like a rhegmatogenous retinal detachment. There are single or multiple breaks in the dysplastic retina over the pit, through which a liquefied vitreous tracks into the retinal layers. Previously, there have been several hypotheses which have been refuted, most significantly by gas, that it is CSF. Now, since pits are congenital, the schisis should be there from birth. Why does it occur later on? It occurs because you require liquefied vitreous on the top of the pit for it to go under the retina, and also vitreous traction on the edge of the pit for the tear to be opened. The fluid is then propelled through the breach, and Doyle et al. Said that an intact membrane seen on OCT in some of the cases protects against the schisis, but there is no further evidence to prove this. Now, how do we diagnose an optic pit? The diagnosis is generally quite straightforward. It's a gray excavation, but there are two situations we should be aware of. You can have acquired pits in open-angle glaucoma. Now, I remember one of my fellow glaucoma consultants diagnosing an optic pit as a case of glaucoma. So you would remember that it's a normal size optic nerve head in glaucoma in spite of the excavation, and the pits in these cases are located on the vertical poles. So in these cases, you have to look at the fellow eye, and if the disc itself is larger, which occurs in 85% of cases of the pits, then it is a pit and not a case of glaucoma. The second pitfall in the diagnosis occurs when the pit is not clinically visible. So sometimes we have a case which looks like a CSCR. You do in fluorescein angiography, you don't see any obvious leaks, just a few little haze in the papillomacular bundle. And OCT typically shows schisis on the nasal side. And this schisis is also accompanied by a pit which can sometimes be seen on the OCT. So the importance of knowing this is, if you have a case of central serous choroidal retinopathy where there is no obvious leakage, watch out the OCT. And if there is an area of schisis, particularly on the nasal side, look at the disc carefully, and sometimes you may even see the pit itself. In view of the poor natural history, shouldn't we treat all the cases? Probably not when the patient is a small child, when the vision is excellent and it is 6'9" or 6'6", and when the duration of schisis is unknown, because it is known to wax and wane. So the treatment of such cases is not clear from the literature, and probably we can wait till the vision drops to a significant level. Now, significance varies according to the comfort of the surgeon, and for me it is 6/12 or worse. It is firmly indicated when there is a progressive visual loss with corresponding worsening of the maculopathy. Now, I have been trying laser for some time, maybe a decade back, and I never succeeded actually. I was successful in about 30% of the cases with such ugly scars on the papillomacular bundle, and the schisis either remaining stable or waxing waning. Subsequently, long-term studies have proven that laser fails to improve the visual acuity or anatomical outcomes beyond observation. And this has been endorsed by a comparative study by Postel et al., who showed that even in natural history of the cases, a quarter of the patients resolve on their own, which is similar to what laser does. So laser has no role. Now, pneumatic retinopathy was proposed by Linkoff, but they've also cautioned that there are recurrences. So probably the only definitive treatments are scleral buckling and vitrectomy. Now, buckling is probably marginally even better than vitrectomy in the anatomical closure, as described by the Greek authors. But because the surgery is difficult, probably it is Greek for most of the authors. Does it mean that when you have a pit with macular artery, we should always jump to vitrectomy? Probably not. Now, this is a patient of 57-year-old man who developed a sudden visual loss of 10 days duration, but the vision was too poor. He was hand motions. Also, he had an RAPD, and if you look at the clinical picture, the macula, I'm not able to find the cursor, the macula detachment looked a little unusual. When I did an ultrasound of this patient, it showed an orbital cyst which was confirmed with the CT scan, and this patient underwent an optic nerve decompression with the excision of the cyst, which was the correct treatment for him. So once we decide that the scarce is due to pit itself and nothing else, we are literally spoiled for choice. Now believe me, there are publications supporting all these, various kinds of surgeries, beginning with only vitrectomy. Vitrectomy always means PVD induction, which is the essential part of the vitrectomy. But what to combine with, there have been several options: laser, ILM peeling, air, drainage, or a combination of all of them. Since it is impossible to have a randomized clinical trial of various surgical options to know which is the best, several reviews converge on the maximum treatment combination, and this works for me also. So I typically do a core vitrectomy, an induction of PVD. I peel ILM to the edge of the optic nerve head. This followed by the fluid exchange. I attempt endo drainage only through the pit, and if I am not successful, I just abandon it. I do not recommend a temporal retinotomy or any retinotomy, even if it is 40 gauge, for draining the fluid, because in most of the cases, first of all, there is no fluid, it is only a schisis. A barrage around the pit, it works in my cases, and recently Spear et al. Also said that it makes sense to do a barrage because it makes the retina compact and prevents the recurrence. So this is one of my early cases. After introducing the PVD, I have used heavy BBG dye. After removing the dye, I start the ILM peeling. Now in this case, because it was a very thin roof of retina over a large outer lamellar hole, I decided to leave a central island of ILM as proposed by the previous speaker on myopic schisis. Now I have done the laser, I am doing a fluid exchange and draining only through the pit. So in spite of leaving the central island, as you see in the figure C, you can see in the figure D that I got a micro hole. Now I call it micro hole because it was less than 200 microns. Because of the micro hole, I chose to just observe the patient. Next month I saw the hole becoming smaller. And finally, you can see the almost complete restoration of the macular anatomy in the figure H. And this patient removes at 20/20. Now look at the picture B. It looks like there is only an ILM remaining, and now you have got the complete retina in the center. So we have to look at the pre-vitrectomy OCT carefully. Outer lamellar holes occur in a quarter of the cases. When they occur, they indicate a chronicity of the schisis, and then be the high chances of post-vitrectomy macular hole formation. It requires a delicate handling, but mostly in terms of PVD induction. Actually, when I did this presentation in Sweden with Dr. Natarajan here, I was asked, why do you want to peel ILM when there is probably only an ILM remaining? As I have shown you before, it is not just the ILM, it is probably an impacted retina, because the whole retina does come back after the surgery. So we did ILM peeling for macular hole in a prospective study of 7 cases. We published our results in Retinal last year. The mean duration of defective vision was 6.5 months. The preoperative visibility was 618. And I did leave an ILM island in the center in 2 cases. In spite of that, macular hole developed in 4 out of 7 cases. In 2 of these cases, because it was a micro hole, I didn't do anything, and the rest 2, I injected gas 2 or 3 months after surgery. Now, if you look at the vision, you'll be surprised. The macular holes closed, and the vision improved in 6 out of 7 cases. The mean post-op visual acuity was 6.9, which was achieved in 5 out of 7, that is 71% of the cases, and 6 out of 7 cases improved in visual acuity. So my rationale is that tangential traction in these cases is relieved only by ILM peeling. The macular holes occur due to PVD induction and not because of ILM peeling. The thin tissue represents the compacted retina and not just ILM. And macular holes have been known to occur and reported to occur in these cases even without any surgery. So the central island doesn't prevent hole formation, at least in my experience, and so I don't recommend it. So to sum up, the optic pit maculopathy primarily consists of a schisis and or not serious retinal detachment or CSR. But it is important to consider the differential diagnosis of CSCR when you have an occult pit. We also should consider the differential diagnosis of orbital cyst when the visual acuity does not correspond to myopathy. Since the natural history of macular scaries is poor and the laser does not work, vitrectomy is the default management. Macular holes can occur anyway, but the surgical outcome was still good. Thank you very much.